Hello, I'm Neil Spooner, the chair of the Patient-Centric Sampling Interest Group, and I'd like to welcome you to today's webinar featuring Karen Perkins from Morecambe Hospital's NHS Trust. She's going to be talking to us today about paradigm shifts in phlebotomy, providing reasonable adjustment for underserved patient populations. But before we get on to listening to Karen, I'd just like to thank our sponsors, without whom we wouldn't be able to provide these webinars and much of the other activities that go on at PCSIG. So thank you to all of our sponsors. Just to remind you that this webinar is being recorded, and in a few days' time will be available on our YouTube channel and through our website. Also, please submit your questions through the chat function, and we'll get to those at the end of the webinar. So that's enough of me prattling on. So I'll hand over to Karen, and I'll see you at the end. Thank you.
Thanks, Neil. Thanks for inviting me to speak today. How do I get to my first slide? I think that's it, isn't it? So I'm going to take you through a little bit about the project that we've been doing here at Morecambe. And for those of you who don't know where Morecambe is, I've put a little map up. So we're at the top bit of England. The Scottish border is up here. Oh, I don't know if you can see me pointing to stuff. Have I got a pointer? I haven't.
I think you can enable the pointer, Karen.
Yeah, I can't see the icon that you showed me before. Don't worry.
It's just above the picture of your slides. There's a little picture of pointer that says pointer settings.
Oh, it's disabled. It's okay.
Okay.
So it's at the top of the green bit that says Cumbria is the Scottish border. So we cover Morecambe Bay, which is the Bay Area, and part of the South Lakes and North Lancashire. So let's crack on. I want to start with this quote from a urologist about 10 years ago, and just have a little think about this. So he says, blood taking is so much more than phlebotomy. It's so much more than the mere act of putting a needle in a patient's arm. It's so much more than filling up a syringe with the most wondrous liquid that will ever be created. It's so much more than filling out a form and requesting an order for someone else to carry out. And the reason I'm showing this is because I'm kind of taking you back a bit. While we talk about automation in laboratories and automated systems and rapid turnaround times and things, there are certain patient groups where the human touch becomes very, very important. And we're talking about patient-centric sampling in this group. And our specific patient group are patients with learning disabilities. So this becomes really important when working with them. So our whole project is focused towards patients with learning disabilities accessing blood samples and reasonable adjustment phlebotomy. So just a little bit of background to this and why we're focusing on this. There's lots of reports out there. One of the big ones, Confidential Inquiry into Deaths of People with Learning Disabilities, or CIPOLD, which came out in 2013. And they summarized really where the problems were with diagnosis for patients with learning disabilities, and actually accessing diagnostic investigations were a barrier to achieving diagnosis and monitoring for some of these patients. And blood sampling is very much part of this, particularly when you're monitoring patients who are on anti-epileptic drugs, patients who are undiagnosed with chronic diseases, and they're unlikely or unable to achieve blood sampling. So further to this, Public Health England brought out a report in 2017 and stated the blood tests for people with learning disabilities should have reasonable adjustments made so they can access phlebotomy. But their report focused on still venepuncture. They weren't exploring any of the other wonderful options that we have now for capillary sampling. And we know that median age for death in patients with learning disabilities was about 62, compared to the general population around 2018, 2020, which is 83 years old. So there needs to be some kind of reasonable adjustment to prevent these patients from dying of chronic diseases or toxicity for some medications as well, which can rapidly accelerate some long-term diseases. We're unable to diagnose long-term diseases in the first place because we can't get a blood sample from them. And about 20% of patients currently with learning disabilities are unable to access annual blood tests. So we're missing those cardiovascular disease diagnoses, diabetic diagnoses, and hypothyroid diagnoses in particular. recently, just at the bottom here, I've put the logo for the Health Services Safety Investigations Body, and this is a body within the UK that pulls out cases which have salient learning points for us, mostly within a healthcare setting, particularly the NHS. And this certain report, which came out in October 2023, was about an adult patient who had been acutely admitted for various reasons. And while he was an inpatient, he was unable, or the patient note says he was unwilling to give a blood sample. The patient did have learning disabilities, but there was no mental health nurse available on the ward. There was no reasonable adjustment for phlebotomy on the ward. The patient was needle phobic. They weren't able to get a U&E sample, so they were unable to diagnose an AKI on this patient or acute kidney injury, and he subsequently died of acute kidney injury. And all he needed was a simple sodium, potassium, urea, and creatinine, or even just a creatinine result would have been something. But he was unable to give that because he couldn't give a venepuncture sample. So there are real life cases where a reasonable adjustment would have saved his life. And we have the Equality Act as well, which was written in 2010, and that states in the UK that we should put in place reasonable adjustments to help people with learning disabilities to use phlebotomy services. But again, this was written in the context of only having venepuncture available at that time, and now we know there are other ways we can do this. And here are some. You're all familiar with these because I'm talking to people who know a lot more about this than I do. But just to say, there are many out there. For our project, we've focused on the TAP device from Your BioHealth, and I'll take you through what we've done with that. So our first step, Andrew Brown, who's one of the consultants here at Morecambe, and myself receive phone calls as clinical biochemists on a daily basis from GPs for various questions about patients or whatever. One particular week, we both got phone calls separately from a mental health nurse and a GP for different patients saying, I'm struggling to get a blood sample from this patient. I really need a TSH on them, or I really need a prolactin on them. What can I do? For TSH, we sometimes offer a blood spot card for them and send it to their local pediatrics laboratory. But for prolactin, we're a little bit stuck, and other analytes, we were a little bit stuck. So we had a little fish around on the internet and came up with all those wonderful devices that are out there now, and thought, oh, that would be useful. So we took the TAP, it was the TAP 2 device we used, and Jo Kilkenny, who's one of our advanced biomedical sciences in the lab, needed an MSc project. So she looked at the first validation of this in our lab, looking at comparison of capillary samples compared to standard venous samples, to make sure that we got concordant results, much as many of other people have done, and there's lots of publication I'll show you later on how we did that. We did need to get ethics approval for this because we were taking a sample that would not normally be taken in a patient, so that was a bit of a pain, but we did this in conjunction with a very willing GP at the Loonsdale surgery, Dr. Tom Jameson, who helps us out a lot with this. So what we did, we had GP patients who were relatively healthy, so they were coming in just for regular health checks, and we took after informed consent, we took contemporary venepuncture samples with a TAP device sample, capillary sample. And the Loonsdale surgery is about a 40-minute drive away. The samples came into the laboratory and we ran them on our DXI 800 immunoassay platform from Beckman Coulter, and our automated chemistry analyzer, which is also Beckman Coulter analyzer. So all of us as clinical scientists, and I think there's a few clinical scientists on the call here as well, will get pediatric samples in that are really, really small. They come in microtainers, and we'll do whatever we can to get a result out of those. So you'll pour them into a hanging cup and you'll look at the volume and think, oh, I think I can squeeze out a potassium on that, or whatever, if it's a decent sample, or a creatinine on that, whatever they need. But what we haven't done, definitely in our lab, was ever do any verification on that. How reliable is that small sample? How low can you go with that small sample? The manufacturer states that there's a total volume you need to present to the analyzer, and that total volume includes the sample assay volume, the dead volume within the system, the pipette overdraw volume, and the sample container dead volume, so what the sample's held in. And that all adds up to say, well, we recommend you use X microliters to present to the analyzer for this analyte. But when you're doing a heel prick sample on a baby, quite often you'll get a very, very tiny, poor quality sample. So we kind of take this with a pinch of salt. But because we were thinking, well, it would be nice if we could offer this as a routine service. Maybe we should do some kind of verification or validation on this. So what Jo did as part of her MSc was a little off piece. So I'm kind of laying myself out for a load of criticism here, but let's see what comes back. We titrated down the total volume. We didn't change any dead volumes or anything like that. We just titrated down the total volume that the manufacturers recommend for each assay type. And we've looked at test profiles as well. So you can see here in the box, we've looked at renal profile, liver profile, lipids, bones, some thyroid hormones, hematinics, and prolactin and cortisol as well. And what we did was for the immunoassays, we just use our internal quality control material to start off with, put them in the 1 ml sample cups that you use for pediatric samples on the analyzer. And we titrated it down in 5 microliter steps for the immunoassay and 2 microliter steps for the chemistry assays. And that's because the chemistry assays use a much lower volume anyway. To see how low could we go. So how long does it take before you get a greater than 5% rejection rate on your analyzer and it says, this is insufficient, I'm not going to do these tests for you. And you can see from this table the percent reduction in sample volume, particularly for some of the immunoassays and notably for a lipid profile, we can reduce that by about a third. So we're looking at reduced volumes, and I've put the microliters right in the far right hand column there, so you can see the total volume that we actually used for those test profiles. And that just gives us a little bit of confidence and leeway to say, well, we've got a tiny sample, but we can reduce. We don't actually need the total volume that they're saying on the analyzer. So we could kind of prioritize which ones we want to do first and maximize the use of that sample. So we did some within and between batch precision, as any good clinical scientist would do, a 3x5x5 design using the CLSI workbook. And again, this is with the QC material, and this is with reduced sample volume. So we went down to a 5% rejection rate, which is kind of what you would see on a pediatric sample anyway, I think. And I've put in the last 2 columns on the right, the within and between percent CVs. The target CV listed there is the target CV that we set in the lab based on 1 month's worth of data from our IQC material at those 3 levels, using the recommended volume of sample to present to the analyzer. So what we would routinely do. So can we match that routinely? And actually, we're not far away from a lot of them. I think clinically they're all pretty well acceptable. Oh, how do I go down? So then what we did, we made up some pooled patient samples. So just found some, took some used serum in the lab, pooled it together, anonymized it all, and made up concentrations that would go across the measuring range and around critical limits, and did the same again. So looked at within and between batch CV and compared this against what the manufacturers recommend in their IFUs as to what we should be achieving for precision on those assays with human serum. And again, this is all done at the lower volume that we've titrated down to, so the maximum use of the sample, and they all seem to pass reasonably well, except for TSH at a higher level, which was a bit unusual. But if your TSH is high, it's going to be high. So I think we can get away with that. And it's if you were using it as an initial diagnosis, I think it's maybe a useful number to have on a patient who can't ever give a venepuncture sample. So we had 74 patients, GP patients at the Loonsdale surgery with contemporary samples following informed consent in an extended clinic, so we could take 2 samples. And these samples were taken in the morning, and we have a routine van pickup, as I said, that takes about 40 minutes to get to the lab at the Royal Lancaster Infirmary. And the samples are receipted and centrifuged immediately on arrival, just as any of other GP samples would be. So the routine process was kept the same for venepuncture and for the capillary samples as well. So we've got some kind of handle on stability of the sample by doing that. Out of those 74 patients, 4 devices were completely insufficient, so we didn't get very good samples at all out of those. 6 samples, we had a lab staff change that week. Jo was on holiday, so someone else took over, and they forgot to record the serum that we obtained from that sample, so we're missing that data, unfortunately. 32 of those, we managed to complete all the tests requested. We had 14 failed attempts, so but we were able to repeat those samples and gain a sample. So I think this was in the first outset when we first started using tap devices, and there's some nuances to using it, but we soon had some help from Your Bio, from Roz and from Pat at Your Bio to help us with that, and that kind of resolved. And surprisingly to me, we only had one hemolyzed sample out of 74, which I was really pleased to see. So sample quality was reasonably good. This just shows, so the 68 samples that we managed to record volumes on, this is the spread of the types of serum volumes that we're getting, and they're averaging around 200 microliters, which is plenty on most analytical platforms to get some decent chemistry results from. I'm just going to show you a few passing bad luck regression analysis graphs here. We did do Altman-Bland as well, and I'll show you some of the bias data, but it's easy visually, I think, just to see where the reliability of these measures are, and also the limitations of the study that we've done. So while we looked at 74 patients, we could only ethically request what the GP actually needed to request on that patient. So some patients had a UNE, some people didn't. So we've got about 20 to 30 paired samples for each analyte that we've looked at. And the number of samples, paired samples, is on each graph. But you can see the correlation. There's a very good association between most analytes. Potassium, it was great that we only got one hemolyzed sample, but potassium did have quite a significant positive bias on it. So we've only got 31 samples here, but it's interesting to start to think, well, maybe we could make or build a new reference range, a capillary reference range for some of these analytes. And that's something that we would love to look at in the future if we can find a little bit of time and money to do that. Albumin looks a bit squiffy here, but again, we've only got 20 samples and we've got 1 point up here and 1 point down there. So I'm pretty confident if we had a few more patients in there, we could straighten that up. And interestingly, the adjusted calcium, which uses albumin for that calculation, has quite a nice association there, slight negative bias, but nothing clinically significant. The lipid profiles were excellent, and the thyroid hormone correlation was excellent, and prolactin too. So I'm not going to take you through every single analyte that we did, because that you would just fall asleep then. But yeah, we were very happy with it. The key bit to it then, so we know that high is high and low is low for the ranges that we've looked at. And admittedly, these were relatively healthy GP patients. So we don't have extremes of, for example, HbA1cs up in the hundreds and things like that, which we do see quite regularly in our population. And we don't have really raised liver enzymes. So it would be nice to find some quite poorly people to get those numbers on as well to further this work. But we looked at reference change value. So this is the value that tells you when it's a clinically significant change, when you need to start thinking, is there something wrong with this patient? So this is listed here as the maximum permitted difference. So analytically, you don't want your bias to be more than this maximum permitted difference. Otherwise, you're kind of interfering with that clinical threshold limit. So we looked at, we used Bland-Altman analysis here, and we've got our mean difference and our 95% confidence intervals around that mean. And if these mean differences exceeds the maximum permitted difference as calculated by the reference change value, which incorporates the analytical CV and the inter-individual variability, which is derived from the EFLM biological variation database, if that's exceeded, then it's not a reliable measure. The analytical variability is going to be too much. And you can see for most of them, does it pass, yes or no? So potassium doesn't. The bias here is quite large, and it's much larger than the maximum permitted difference according to the RCV. But for the other analytes, total protein was borderline. It's just kind of touching there, minus 8.21. So one side it's a bit higher, but the other side's not too bad. So maybe you could use that for something, maybe a bit more data. Albumin didn't pass either. But the other analytes look pretty good. And I've listed a few more of the endocrine and immunoassays here. These were all really acceptable. And of course, they have quite wide spreads around the mean differences there. So we're quite happy with that data, although it's a smallish data set. So ferritin, for example, we've only got 15 concordant samples there. It's enough for us, I think, to say, in a patient who's never been able to give a venepuncture, has never had any blood testing done, sometimes giving them a ballpark figure is better than no figure at all. So we thought, well, let's try this in a patient population. There's lots of publications out there, and some that have come out quite recently as well. This is 2024 this year, and I'm sure there's others since then as well, that have done very similar things to us, but perhaps with bigger data sets. We're in a very a limited NHS laboratory, as I'm sure many of you will understand and appreciate that resources are slim. So we did what we could with the money that we had, so to speak, and the time that we had. So it would be nice to go back and extend what we've done to build the data set to make it really solid. But there is a lot of data out there already, which gives us some reassurance that we're seeing the same things that other people are reporting with these types of devices. So we wanted to pilot this in patients with learning disabilities. So first of all, we needed some kind of request form because these are small samples. So what we've done is we've made like a priority request form. So kind of in the event of this being a really tiny sample, what test do you really want for this patient? If you could have one thing, what would it be? And you can prioritize that, so we can then put it manually on our analyzers, so it doesn't just send it around the track to whichever thing it feels fit. It's actually we're proportioning the sample out according to which are the most thirsty assays and which ones are needed most importantly for that patient. So it's a bit more of manual interaction in the lab. So the lab staff are quite enjoying that because they really feel that they're connecting with patients and doing the best they can for those patients. But it's also really helping the patient and the clinician treating that patient to say, well, we have a chance here of getting some data on this patient who's never had a blood test. So this seems to be working quite well at the moment. This is one of our patients here, and you can see the tap device stuck to her arm there. She'd never given a sample for 5 years and was so pleased with it that she gave a good testimonial and was happy for us to use a photo as well. And she came back for a second sample as well, following this one, to get some extra diagnoses done. There is Public Health England guidance identifying a range of good practice interventions on patients with learning disabilities, and it's mostly focused on desensitization. So this means trying to build confidence in your patient to either get a finger prick sample or a venipuncture sample. A lot of patients with learning disabilities are needle phobic, or they really are terrified of just coming into the clinic as well. So being in a different setting is difficult for them. So if we can do this at home, which capillary sampling enables us to do, it's a win-win. I have an anecdote from one mental health nurse who spent 3 months with a patient building trust just to be able to hold his hand to get a finger prick sample from him. And that in that situation, it's very, very difficult to get anything, and he'd never been able to give a blood test. So they're looking at using general anesthetic, which is costly and risky for the patient. So this is a wonderful alternative. This is one of our peer workers who has learning disabilities, we're just doing a bit of training using the tap device, and she was very willing to have a go at it. We made sure that the development of patient information sheets, of consent forms, were all adapted for patients with learning disabilities, and we ran them by some of our colleagues in the mental health team as well to make sure that they were all appropriate for use. And the patients we used in the volunteered in the pilot study were all able to give informed consent themselves. So we had a mental health nurse doing capacity assessments with these patients at this stage as well. And we gave them questionnaires as well to see if we could get some qualitative data, and I'll show you that in a bit as well, as to how they found it and would they do it again. So we had benchmarks for this pilot, and this was access. So to increase the number of people able to provide blood samples, which is essentially from about 0 to whatever we can. And we wanted to find about the patient's experience as well. So qualitative responses to post-procedure. And outcomes here was, do we diagnose anybody with anything who'd never had it before? Or can we say they're okay? Or would there be a change in the medication management? Things like that we've recorded. So this is just some of the data from the first 20 patients we've done in the pilot study. When was the last time you gave a blood sample? So 30% of patients had managed to give a venipuncture in the past year, but greater than 5 years, there was also 30% of them had never been able to give a sample in 5 years, and 15% had never, ever been able to give a sample. So that's quite a significant portion of our learning disability population if you extrapolate it to everybody on our LD register across Morecambe Bay. How did they feel about it? Most people said it was good. Some people said it was all right. Everybody said they would do it again. And we did have a few patients who came back a second time to get more blood so we could complete a whole panel of tests for them. And everybody said they would tell a friend to try it. So that's a really great positive feedback we got there. And here's just some of the quotes from the participants and the carers as well. And you can read through those. The one I think is most salient is the one at the bottom. Major step forward for our son, who will not give blood unless under a general anaesthetic. And that's a major stress for the family, for the patient, and it's risky and it's expensive as well. So if we can avoid things like that for these patients, I think that's just fantastic. Sarah, our mental health nurse who's helped us on this project, always says if you can get it right for LD patients, you can get it right for anybody. So I think we've started at the extreme of patient-centric sampling. And hopefully everything we do from here will be much easier, but it's been a challenge to start with. We're in the process of project planning, rolling this out now across Morecambe Bay as a routine service. And it's involved some quite significant changes within the laboratory in our workflow, but we're all willing to do it because it's something that's really going to help people, and I feel it's a way that we can work in the future. A change in blood sciences processing, so it's a paradigm shift in phlebotomy, but it's also a shift in the way that we work within a clinical laboratory as well. So the outcomes from these patients, we had one hypercholesterolemia patient who's went on to go to take statins, and a CVD review has been arranged. We've got one elevated HbA1c and a hypoglycemic patient, so that patient can be treated. And we found 2 hypothyroid patients who can now have thyroxine treatment, who we had not managed to access blood from before. So I think we've achieved all our targets from that pilot, in that it's become accessible for the patient. The patients have given positive feedback about the use of the device, and we've also made diagnoses and altered management of patients as well based on the results we've been able to obtain. There's another side to this though. We're not always looking for abnormal results, but to have normal results is reassuring. And this picture is one of our patients at the GP practice where we did the pilot study in Carnforth, and her sister, who's a carer. She's a 39-year-old female and her BMI is over 40. So a carer is very worried about heart disease, metabolic syndrome, diabetes, all those kind of things. She also has congenital cardiac disease and epilepsy. So she's on some quite heavy duty medication, and she'd not been able to give a venepuncture sample for over 5 years. And she's now unsuitable for desensitization because she's previously been traumatized with venepuncture. So mental health nurses say once you've had that traumatic experience, you can't really go back there to revisit it. Kind of that's it. You're looking at general anesthetic to obtain diagnostics. But this patient came and used the touch-activated phlebotomy, and we were able to obtain results which were all normal. So lipid panel, HbA1c, UNEs, LFTs, and everything came back within reference range. And the carer was so relieved because she knows now she doesn't have to worry for another year, and she knows also that in another year's time, her sister will be able to access phlebotomy to make sure that everything is okay. So there's a benefit to having normal results as well. We're not just looking for the abnormal. And just to finish up with, this is the team. So Joe Kilkenny was the BMS who did all the validation work in the lab. Dr. Tom Jameson at the Loonsdale Surgery helped us obtain those samples. Pat Holman and Ros Barker have been absolutely brilliant at Your Bio, and unfortunately don't work with Your Bio anymore, but we still keep in touch with them. Pat did a lot of the training, how to use the TAP device, and introduced us to it as well. Dr. Julia Smith was at the Carnforth Medical Practice, Parkview Medical Practice in Milnthorpe, and she and Sarah Duffin, who's the mental health nurse, ran the pilot study for us. And Andrew and I, our mugshots are there as the nerdy biochemists who are the twisted fire starters in all of this. So thanks to them, we couldn't have got this far without them, and we're looking forward to working with them, rolling it out across the bay now. So I'll leave it there, and thank you all for listening.
Thank you, Karen. That was phenomenal. I think that's just a phenomenal case study of the benefit of these technologies really making a difference to patient lives. So I'll just click through. So we're starting to get some questions in. I'm going to read them through in order that they came in. First one from Amy. Were any other changes made to the assays to reduce sample volume, change in reagent volume or incubation periods?
No, we didn't want to change anything because the idea is this becomes part of our routine workflow in the lab. So we use Beckman, and the Beckman immunoassay in particular is quite a thirsty beast. It uses a lot of sample. So there's big dead volume, there's big sample volume that's needed for the test itself, but we didn't change any reagent volume or anything like that. It was all part of the routine. Stick it on the analyzer, let's go. Nothing else changed other than putting it in a hanging cup and changing that maximizing the use of that sample volume.
Cool. Thank you. We've got a question from Graham here. Hi, Karen. As a father of a non-verbal autistic son, this is simply wonderful to see.
Thanks.
We can't get blood from him with a general anesthetic. $64,000 question. Are there any other NHS trusts showing interest in adopting these approaches?
Yeah, and I think some of you guys are on the call today, aren't you? Which is great. So we've got some groups in Northern Ireland who are looking at it, 2 down in London, and I'm sorry if I've forgotten who the others are, but we're talking. We have a little email chat every now and then. I've shared with them everything that I've done here, in the hope that we can get everybody using this. I'm happy to share whatever. It's a no-brainer, in my opinion, that we should all be offering this for this patient group. But it takes a lot of hard work in the outset to get your clinical laboratory to be able to establish it as a service. So it's not just a case of buying it off the shelf. There's all the problems with NHS procurement. There's all the problems with having the time and the funding to buy the devices in the first place to do the validation work, because we all use different analytical platforms. We use Beckman, other labs use Roche, others use Siemens, there's Abbott. So, and they all do slightly different things and work in slightly different ways. So there's a lot of work to be done, I think, but we're talking about forming a working group so we can all share our information together with the use for it for patients with learning disabilities. So the whole patient pathway and the access pathway, I'm happy to share that with our working group that we've got as a little email group at the moment. So yeah, it'll come.
That's phenomenal, Karen. Question from Amma. Hi, Karen. Thank you for such a wonderful talk. Just wondering, could any analyte concentrations vary with the site of sampling? For example, heel prick versus arm prick. Are there any adjustments for that?
Yeah, I don't know is the answer, but wouldn't that be a great study to look at, particularly for pediatrics, because a nice juicy baby thigh, I think, would be a really good target for one of these capillary devices. But I have no idea if it's going to be different to an upper arm sample. I would imagine some of the manufacturers might now have some data on that. And from what I've found from a lot of the manufacturers of these devices, they're really willing to talk to clinicians and clinical scientists about this, because they know as well that it's a good thing for patients. So yeah, phone the manufacturers, find devices and try them and use them. Yeah, I wouldn't like to write the ethics approval for doing that study though.
Yeah. Question from Amy. It's clear that this process is less intimidating for anyone, especially this population, but I'm curious what the process was that enabled you to get the patient to the point of collection. Were they told in advance about the collection? Was it up to the parents / caregiver to decide how to explain this to the patient?
Yeah, that's a really good question. And that's why we worked with our mental health team and our patient peer representatives to say, is this acceptable? And to see if they experience things similarly to a neurotypical person as well. And so some of the pilot study volunteers or patients were sampled at home. So we had one example, he's in 24-hour care and goes home for weekends. So our mental health nurse, Sarah, arranged with his mum to say when would be the best time to come and try. And she said, well, he's most relaxed when he comes out of the bath. So Sarah went over and waited for him to come out of the bath. And of course, he's nice and warm out the bath as well. So capillary flow is maximized, and got a really successful sample from him. And he'd never been able to give a blood sample before. So yeah, it's patient centric entirely. So it's wherever that patient is, wherever they feel comfortable. Can we equip our mental health nurses with devices like this? And they know they can collect that sample wherever that patient is, drop it off either at the GP practice or straight back to the lab, and we can do whatever we can with whatever serum comes through the door. So yeah, it's truly patient-centric.
That's phenomenal, Karen. Question from Jolene. Was there anything special about the outlier samples for albumin?
No, I think it's just down to numbers. There was nothing special that I could see. No clinical strange things. They weren't lying down or anything like that. No, I have no answer for those. And it's a relatively small sample size. So they may be anomalies. I'm not sure.
Okay. Question from Greg. Wonderful talk. Thank you. Do you know what were the main issues associated with 16% of devices that failed?
No, is the answer to that. It may have been the tap 2 device has the tube attached to it already. It comes as an integral unit, whereas the microselect you can put on whichever BD microtainer you choose. So we used tap 2 for that validation study. I think in the outset we were a bit hesitant. When you push the plunger, you do need a bit of a hard push. So I think Tom, he felt he was, maybe pushing too hard on the patient's arm, so the vacuum seal wasn't quite as good as it maybe could have been. But we did get better with time. Interestingly, we had a couple of very poorly controlled diabetics at the first few patients that we did, and we had really poor sample collection from them. And I guess that's because of very poor peripheral blood flow. So it would be interesting. My first thought was, let's put this in a diabetic clinic and see how it performs there, because that would be a useful thing to do. Patients could do it at home, send their samples in, and we can monitor them that way. So that would be a neat next step as well. Another patient group to do.
Question from Christian. Any plans to look at genetic samples in the future, which would be particularly important in the undiagnosed LD population?
Yeah, not from us. We're not a research laboratory. We're a clinical laboratory, but I'm pretty sure somebody must be looking at that. Yeah, it's a great idea.
Okay, thank you. Any more questions, please send them in. There's a question here from Jason. Very good study. So did your institution end up validating new reference ranges, or correction factor was used to keep the reference ranges in sync with venous sampling?
No, I would never support using a correction factor to start off with. We don't use a different reference range. We don't offer potassium as part of our U&E profile using capillary sampling as a result of this, because while the sample quality was really good, and we did see a significant positive bias, we don't have enough samples to create a reference range. I would like at least 100 potassiums across the measuring range of our analyzers to be able to establish a new reference range. And I don't have the time and money to do that, unfortunately. But if anyone wants to do that, I'd be willing to listen. So no, we don't offer potassium on this study at all, on this service.
I had one question, and I think you may have mentioned it earlier on. What's the stability period and conditions that you have between collection and you being able to analyze the samples, please, Karen?
Yeah, so we haven't done specific stability studies on these, but the Loonsdale surgery is probably one of the surgeries that's furthest away from our laboratory, and they have a van pickup from that surgery routinely at 1 o'clock and another one later in the afternoon, I think, that comes to Lancaster Infirmary Laboratory here. So it was handy that we managed to hook up with Tom to do this study, because by default, the stability is going to be compared to what we do with our routine venepuncture samples from that GP practice. So the samples were collected in a morning clinic. They were sat there until 1 p.m. when the van picks it up. 40 minutes later, they arrive at the laboratory and they're processed with regular samples. So there's probably another 10 or 15 minute delay while they're sorted and processed and booked in. So we're matching stability of what we would see on our standard venepuncture samples. We haven't changed our routine process, which is part of the beauty of this, that you can electronically request the test from a GP practice. We can deliver the samples or make sure there's supply of devices, collection devices to that GP practice or the mental health nurse. The patient can be sampled wherever they need to be, and the sample can be dropped off at that practice straight away. I'd say probably within an hour or half an hour, it can be back at that practice. So, and then it can come in on our routine transport. So we don't have to do anything special. And the results that we've got show that there is concordance between the capillary sample and the venepuncture sample. So that looks good to me, but we haven't done, how many hours can you leave this for before you bring it in, and temperature variation and stuff like that. So yeah, it's again, another study worth doing, but we need time and money. So.
No, I understand. And while I'm waiting for any other questions to come in, I guess that was the other question. All health systems, money is a limiting factor. So, how much of a barrier is the financial barrier to being able to use this technology for different patient populations?
Yeah, I think the hard bit is because it's not part of NHS procurement. So to get your procurement and finance team to say, yes, you can buy this, because it's not on the NHS, or many of them are not on the NHS catalogue, it's very difficult to make a purchase for it without kind of a separate purchase order for research kind of stuff. It's changing slowly, and I think labs are becoming aware that this is a useful thing to be doing. And there's also questions as to who pays for it in the NHS. We've worked across care providers, so we worked across primary care, secondary care, and tertiary care essentially. So and they're all different pots of money. So depending where that patient sits, who pays for the devices. So it becomes quite political after a while, which is a bit worrying. But hopefully with the creations of these integrated care systems across the UK and pathology networks, hopefully it will become simpler in the next few years. It's definitely a discussion worth having with your finance team to say, we'd like to buy some of these. Whoever buys the blood bottles to start off with, I think it sits with that pot of money, in my opinion, but different trusts do it in different ways.
Yeah. I'm guessing this is the kind of thing we're going to be talking about at the event, the Association of Laboratory Medicine event in Liverpool on the 11th of February. If I just give us a little plug for that event that Karen's helping to organise in February in Liverpool. It's the sort of thing that's going to be top of a lot of people's thoughts when we have that discussion in a couple of months' time.
That's exactly it. So thanks for that, Neil. I wasn't sure whether I was going to be allowed to plug that or not. So I will now, seeing as Neil's helped us organise it. So this is under the banner of LabMed UK, which is the Association for Laboratory Medicine in the UK. And we have got a one-day symposium in Liverpool on the 11th of February. So if you go to the LabMed UK website, you'll see it advertised on there just now, and you can register right now. And the symposium is there. We've got regulatory speakers, we've got patient experience speakers, we've got clinical scientists, we've got examples in the private and the public sector of where this kind of workflow and validation is working well. So hopefully we can bring everybody together on one day and start to build best practice guidelines for clinical laboratories. So it will be easier for us to put this into our workflow process, and all those questions about procurement, regulation, hopefully we can start to build some answers to that so people can just go out and buy them and use them would be ideal.
Yeah, it's a really exciting event, and Graham says already registered, looking
Excellent.
forward to it. So no, I'm very much looking forward to that.
Me too.
So it looks like there's no more questions. So we'll just tidy up with a little bit of advertising for our next event. So thank you so much, Karen.
Thank you.
That was
Thanks
a
for
phenomenal presentation. Great set of questions from the audience and great answers from you. So just like to, this is our last webinar of 2024. Our first webinar of 2025 is Vincent Molnar, who's going to be talking to us about some of his PhD work, Unlocking the Future of Blood Collection, a step-by-step guide for the performance assessment of capillary sampling methods. So Don't forget to register for that. You can get the link through the Patient-Centric Sampling Interest Group website. We now have webinars booked up for all of 2025, and we've just booked our first one for January 2026. So we've got plenty of exciting presentations coming up in the next year or so, and all our webinars are available through our website and on our YouTube channel. So please take a look at that. Just a link there to our website. If you're not a member of our LinkedIn group, you can use that QR code to get through to that. I'll just leave those up for a moment. But yes, please join our LinkedIn group or take a look at our website and join any of our working groups that you can find out more information about on our website. And again, I'd just like to thank our sponsors who enable us to do all of these activities and have these wonderful webinars like Karen has just presented. So with that, I'd like to say thank you to you all, and I wish you all the best for a wonderful Christmas and a happy New Year, and see you all in the new year. Thank you.